Hi, I'm Dr. Reinoso. I'm a sleep medicine board certified physician and a fellow of the American Academy of Sleep Medicine. Today I will be talking about non-restorative sleep and sleep deprivation. Both are prevalent in patients presenting to our clinics. First, I will define non-restorative sleep and the relationship of this symptom to other common presenting symptoms. I will also put in perspective the implication of using these terms. After this first short presentation, we will make a break and return to discuss more in depth the topic of sleep deprivation. So let's start with the first slide. What is non-restorative sleep? In the most current revision of the International Classification of Sleep Disorders, it is defined as sleep that is perceived to be poor in quality, unrefreshing, and that results in a sense of feeling unrefreshed when patients wake up. This term has been used as part of the definitions in multiple sleep disorders, such as sleep apneas, insomnia, but also in the general literature as an isolated symptom. As we can see by now, the term non-restorative sleep is non-specific, and when used by patients and physicians, should not imply a specific diagnosis. As part of diagnostic criteria, the term non-restorative sleep has been kept, deleted, or even substituted in different editions of the International Classification of Sleep Disorders. In any event, the term non-restorative sleep can still be useful when communicating with patients and physicians, as long as we understand that it is a symptom and not a particular entity. Two other sleep-related symptoms are important to evaluate presenting to our clinics. Those are fatigue and sleepiness. Actually, both tend to be used interchangeably by patients many times. But it is useful to determine if the patient is expressing the actual propensity to fall asleep if the circumstances are right, and or they are expressing a lack of energy that tends to limit the patient's activity. Determining the presence or not of this presenting symptom will help us in narrowing the differential diagnosis and better direct our diagnostic efforts. It is also important to define the terms fragmented sleep, insufficient sleep, and insomnia. The term fragmented sleep indicates short sleep interruptions, implying that the patient is able to go back to sleep relatively fast. On the other hand, sleep maintenance insomnia should be used when a patient wakes up during the night and struggles to get back to sleep. The term insufficient sleep relates to a short sleep time without significant sleep fragmentation that is not due to other sleep disorders, and it gets better with extended sleep time opportunity. Fragmented sleep and sleep maintenance insomnia are both problems derived from poor sleep quality. Insufficient sleep syndrome is a quantity problem and is usually behavioral induced. Not infrequently, patients have a combination of fragmented sleep, for example, due to sleep apnea, who also have sleep maintenance insomnia due to depression, and that in addition has insufficient sleep syndrome due to his work schedule. Determining the contribution of each of these events is important to treat these patients. Let me summarize in this slide the components of a healthy sleep that when disrupted may produce a complaint of non-restorative sleep. Sleep can be seen from the conceptual and practical point of view as containing multiple domains. In a patient with non-restorative sleep, those domains are important to be evaluated. These include quantity, quality, regularity, and timing of sleep, along with related domains of satisfaction and alertness. In terms of quantity of sleep, the American Academy of Sleep Medicine and the Sleep Research Society have recommended for adults from 18 to 60 years of age 7 to 9 hours of sleep as optimal. Sleep duration of 6 hours or less was determined as non-sufficient. Two gray zones are 9 or more hours of sleep and the 6 to 7 hours range that probably falls in the inappropriate range. Quality domain, as we saw it before, have to do with sleep fragmentation. This can be evaluated by determining awakenings and arousals. Regularity has to do with sleep schedule. Timing on sleep relate to our 24-hour period that can also influence the two other domains, such as sleep satisfaction and alertness. After this part of my presentation today, we can appreciate the importance of defining and evaluating the patient's symptoms by a careful history. In my second part of my presentation today, I will go into more details about the evaluation and the management of sleep deprivation. I will see you later.